Welcome to this explainer. Today we're diving into some fantastic material from the Anesthesia Learners Academy to tackle a topic that honestly, notoriously trips up test takers and clinicians alike. We're talking about the anesthetic management of myasthenia gravis. By the time we're done here, you aren't just going to be guessing board answers, you'll be deriving them from pure physiological logic. Let's get started.
All right, here is our game plan to completely replace rote memorization with true physiological understanding. First, the docking station problem. Second, the pharmacology paradox. Third, navigating the reversal trap. And finally, post-op ventilator red flags. So let's jump right into section 1, the docking station problem. We really need to understand this neuromuscular junction deficit first. Now, to truly grasp the anesthetic implications, we absolutely have to start at the source. Myasthenia gravis, or MG, is a rare autoimmune condition where the body's own autoantibodies systematically destroy the postsynaptic nicotinic acetylcholine receptors, right at the neuromuscular junction. By destroying these specific receptors, the disease drastically decreases the patient's margin of safety for muscle contraction. Think about it. The nerves are firing perfectly fine, but the receiving end? It's heavily damaged. This brilliantly illustrates the core issue. Think of it like a chaotic game of musical chairs. The signal, which is acetylcholine, is looking for a place to sit down, but half the chairs have already been removed from the room. There simply aren't enough spots for everyone to land. This lack of docking stations means those nerve signals literally cannot land effectively, which is exactly why these patients experience such rapid, profound muscle fatigue.
Moving right along to section 2, the pharmacology paradox, keys versus boots.
This is where it gets absolutely fascinating, and this contrast explains the paradox perfectly. For depolarizing drugs, like succinylcholine, patients are incredibly resistant. Why? Well, because succinylcholine acts like a master key that needs to turn on multiple ignitions to start the engine. If the patient has very few ignitions left, you need a massive handful of keys just to find the working ones. On the exact flip side, patients are profoundly hypersensitive to non-depolarizing drugs like rocuronium. Rocuronium acts like a parking boot. It doesn't turn anything on, it just blocks the wheel. If a healthy person has a fleet of 100 cars and our MG patient only has a fleet of 10, it takes very few parking boots to completely paralyze their entire system.
So the clinical reality of that resistance is kinda wild. To get succinylcholine to work, you actually need to give up to double the typical dose just to trigger that initial muscle activation. And for your exams, you definitely want to remember that pushing the dose this high carries a very real risk of triggering a phase 2 block. That's where the drug starts behaving unpredictably, almost like a long-acting paralyzer.
Section 3, navigating the reversal trap. Let's talk about avoiding the cholinergic crisis.
We really have to ask ourselves this critical question. Picture this. We just paralyzed the patient. The surgery is completely done, and now we need to reverse it. Why on earth does the traditional cure for paralysis cause a massive crisis in an MG patient? We have to understand the severe danger of using traditional reversal agents, specifically neostigmine, in this exact patient population.
It really comes down to distinguishing between two very different types of emergencies. A myasthenic crisis is severe weakness because the disease itself is flaring up. The body desperately needs more signal to move. But a cholinergic crisis is severe weakness from overmedication. The body actually needs less signal. You see, traditional reversal agents like neostigmine work by flooding the neuromuscular junction with acetylcholine. By flooding the area, neostigmine can instantly trigger a cholinergic crisis. It's literally like trying to pump 10,000 volts of electricity into a dim light bulb. It doesn't get brighter, it just burns out entirely and the patient becomes lethally weak. So, the absolutely crucial takeaway here is that Sugammadex is the definitively safer choice. It is the gold standard. Instead of messing with the electrical signals and risking a total burnout, Sugammadex acts like a chemical magnet. It simply pulls the paralytic drug away without ever even touching the receptors. Now, as a quick aside, to avoid this entire trap altogether, many anesthesiologists actually prefer a completely relaxant-free technique for these patients. They rely instead on high doses of short-acting opioids, like remifentanil, to keep the patient still during surgery.
Okay, on to our final section, section 4, post-op ventilator red flags, predicting the breathing tube. You are going to want to memorize this exact checklist for your boards. If a patient has severe disease requiring high daily medication doses, comorbidities like COPD, lower than normal lung capacity, or bulbar symptoms like difficulty swallowing or speaking, their risk for needing post-op ventilation just skyrockets. And keep in mind, this is super tricky because these patients can look remarkably strong immediately after surgery. But because of that diminished margin of safety we talked about, they can experience a rapid, highly dangerous fatigue an hour or two later in the recovery room.
But I want to single out one specific metric right now: a disease duration of greater than 6 years. This 6-year threshold is a classic high-yield board exam favorite for predicting the need for post-operative mechanical ventilation. If you're reading a question stem and you see 7 years of MG, red alarms should be ringing in your head.
Bringing it all together, here's your definitive pharmacological playbook. I highly recommend screenshotting this for your exam prep. It perfectly contrasts the resistance to depolarizers, which require double doses, against the hypersensitivity to non-depolarizers, which require tiny doses. And it clearly marks the high risk of neostigmine against the absolute safety of Sugammadex. This is your entire exam strategy synthesized into one neat visual.
As we wrap up this explainer, I'm going to leave you with a final provocative thought to really test your grasp of this receptor logic. If an MG patient presents to the ER in a true myasthenic crisis where they need more signal, how does their immediate life-saving treatment completely flip the rules of the cholinergic crisis we literally just learned about for the operating room? Think deeply about those docking stations. Thank you so much for joining me today, and I wish you the absolute best of luck on your board preparations. Keep focusing on the physiology, and I promise you the answers will follow.